All right. Well, it is officially 12:02, so we're going to go ahead and get started. First off, I want to thank you all for attending our Q-Centrix assessment, the blueprint to unlocking value in your enterprise clinical data strategy webinar. Today, we're joined by two Q-Centrix partners, Claire Lozon-Vallone from CHRISTUS Health and Ann Van Buren from Ohio State University Wexner Medical Center for a discussion on the complexities of registry operation management, some of the common challenges of the current market, and the value of an assessment in unlocking an enterprise clinical data strategy. Joining our panelists today, we also have two Q-Centrix experts, Doug McGill and Daniela Wood. My name is Eric Kreitz. I'm the Vice President of Enterprise Services here at Q-Centrix, overseeing our advisory solutions organization and our enterprise growth initiatives. And we'll be your host today. So I'm going to quickly review just a couple housekeeping items. And before we begin, first and foremost, all participants have been muted to maintain the quality of today's discussion. If you have a question for today's presenters, please, by all means, submit those to the QA button located in your participant controls at the bottom of the screen. If we do not get to your questions, rest assured, we will absolutely follow up with you via email afterwards. If you'd like to refer to the webinar or you want to share it, please, by all means, do that. And the webinar is being recorded, so we'll share that via email within the next week. And finally, once our webinar concludes, we're going to have a link that pops up with the post-assessment webinar, post-webinar survey, and I just appreciate anybody to participate in that and fill that out. And that's it for our housekeeping. So without further ado, I'd like our panelists to come off video, if they haven't already, and we'll go through some introductions. First off, let's hear from our health system partners. Ann, could you please introduce yourself?
Sure. Hi, everyone. Thanks for having me. I'm the director in the Quality and Patient Safety Department at the Ohio State University Wexner Medical Center. I've worked at OSU for over 30 years, and I'm happy to be here with you all today.
Great. Thank you, Ann. Claire, could you please go next?
Yes, good afternoon, everyone. I'm Claire Lozon-Vallone. I'm the Vice President of Quality and Safety for CHRISTUS Health. I've been with CHRISTUS Health now over 5 years. Thank you.
Great. Now on to members of the Q-Centrix team that you'll be hearing of. First off, Doug.
All right, thanks, Eric. My name is Doug McGill. I'm the lead consultant for advisory solutions here at Q-Centrix. I've been with the organization about 3 years, and prior to joining Q-Centrix, I was actually a client of theirs at the University of Pittsburgh Medical Center for a number of years, where I led the clinical quality data program for that organization.
Thank you, Doug. And last but not least, Daniela.
Hi, my name is Daniela Wood. I currently serve as the enterprise analyst for the advisory solutions team at Q-Centrix. I drive the surveying and analytic components of the enterprise assessments and work closely with Doug to pull the assessments together. Before Q-Centrix, I worked at a small consulting firm, and I was focused on population health, contributing to health system immersions and the development of real-world evidence and best practices.
Appreciate that. And as I mentioned in the opening remarks, my name is Eric Kreitz. During the discussion today, you'll hear some of the hurdles the panelists have had to overcome or are in the process of addressing to efficiently leveraging their enterprise clinical data. I encourage you all to listen for ones that you might be experiencing too. And to set the foundation for the discussion, I'll point out 4 of the most common hurdles that we're seeing today. And the first one's on coordinated registry management, which really translates to silos and lack of communication throughout the health system. And as health systems continue to acquire, merge, and grow, this continues to be a major, major challenge. The next is having little emphasis on data science. Too often, enterprise clinical data participation is really just a check-the-box effort for a lot of hospitals. Organizations submit to the registries, but ignore any true opportunities to use the data for improvement purposes. And the third shortfall is having too much time or too many advanced licensed individuals dedicated to low-value activities. When you layer in the painful staffing shortages that I imagine many of you on this call are feeling, this shortfall is particularly penalizing as of late. The final hurdle that we'll talk about is organizations is dealing with the lack of information management strategies. So this means no common platforms being utilized to gain immediate insights that lead to really meaningful changes for health systems. So with that as foundation, now it's your turn. And we're going to put up a poll here, and we want to hear from you. Of the challenges I just mentioned, which is your biggest hurdle in managing your enterprise clinical data? All right. Perfect. Yeah. And those, and it's across the board, really. It's and that's great for the discussion that we have here today. A lot of you are on the same page, and based upon what I'm seeing here, I'm confident that we'll be able to provide you some takeaways and ideas and learnings from the discussion that we're going to have here today. So without further ado, let's get chatting with our panelists. And Doug, let's start with you. As I mentioned earlier, and as we saw in the results of the poll, there's a wide range of challenges that hospitals are facing. And many healthcare systems are now turning to enterprise clinical data assessments. Can you tell us a little bit more about what an enterprise assessment involves and how they can provide a blueprint for hospitals and healthcare systems?
Sure, Eric. So the goal of an enterprise assessment really is to better understand each quality program and help identify opportunities for greater support, efficiency, utilization, and ultimately impact. How we do this is by identifying each quality program's associated technologies, production workflows, workforce, reporting tools, how they're utilizing the data, and we roll all of that up into their total operating cost. And by aggregating all of these often disparate programs together, we're able to show the total cost of ownership of the clinical quality data management program, or the aggregate investment across the organization in this space. We also analyze what value these registries are currently providing, the current return on investment, if you will. So the assessment is both a current state analysis and an improvement tool for outlining future opportunities.
Doug, sticking with you for just one more question here. I touched on this a bit during the introduction, but would like to ask you to elaborate on it some. And that is that just this current expansion of healthcare systems and overall market consolidation, how are hospital mergers and acquisitions affecting clinical data practices?
Sure. So as I mentioned in my introduction, I was previously with a large health system in Western Pennsylvania, where I worked a lot on their registry centralization efforts. And when I started there, we were a health system of about 10 hospitals. And when I left, we had grown our network to over 40 hospitals. And my tenure with the organization was really marked by mergers and acquisitions and needing to understand how to align and centralize teams and data. Because clinical quality data generally isn't a leading piece of merger activities prior to approvals and signatures, I often was trying to determine the registry and regulatory participation infrastructure and kind of overall operations well after the ink had dried on those contracts, and in some cases, several years after the fact. The main goal in most mergers and acquisitions is synergies from scope and scale that you hope will lead to reduced costs and greater service impact. And on a much smaller scale, it's the same for the clinical quality data programs. And so, what we're hoping for is to be able to understand what those synergies are, and also, when do they fail to materialize? And in particular, it's true in the clinical quality data space, mainly just due to the disparate nature that these programs historically have had. There are many unique attributes within each registry or regulatory reporting program, and to maintain and manage these programs well often requires a considerable amount of operational savviness and just technical specification expertise. And like many challenges facing healthcare leaders today, the biggest hurdle often isn't finding the time to develop that expertise. It's just there's so many other competing priorities that you're trying to deal with.
Thanks for that, Doug. And speaking of healthcare healthcare leaders. We have two great ones on the call here today. So Ann and Claire, thanks again for joining us today. And to ground the listeners on your organization, can you just share some background on your health system and some of the reasons why you chose to move forward with an assessment? Having both completed one now, what would you say was the primary value that you saw in it? And Ann, let's start with you on this one.
Sure. So the OSU Wexner Medical Center is comprised of 8 hospitals. It's the only academic medical center in Central Ohio. We have a unified physician practice group, including over 1,700 physicians and a network of community-based primary and specialty care facilities. And at OSU, we have a centralized quality and safety department. However, registry management is somewhat siloed. And I primarily oversee clinical registries and quality reporting that's required for regulatory agencies or accreditation or reimbursement. But there are several registries that are managed by individual programs or departments. And so my goal with the assessment was to understand the big picture in terms of the volume of cases that are reviewed annually, the amount of backlog that we had, various staffing models, cross coverage and validation processes, and really to be able to compare our productivity and efficiency with some national benchmarks. I also wanted to evaluate our vendors and the cost and benefit of participation and how the data is being used for process improvement, which is ultimately the goal. And I also felt like the assessment would give me an outside objective perspective and save me some time putting all those pieces together.
Great. Thank you for that, Ann. And now switching gears with Claire.
Thank you. CHRISTUS Health, it's an international Catholic faith-based organization. We have hospitals in the United States and in Latin America. CHRISTUS Health has 26 hospitals in the US, in Louisiana, New Mexico, and Texas. And one of the reasons for choosing to do this assessment was that we have registries in all of our hospitals, but they're all decentralized. And so anecdotally, we knew that there needed to be some connectivity of understanding and transparency of how these registries were operating, but we didn't have the bandwidth to go ahead and pull that all together, very similar to what Ann was facing in some of her journey. So one of the things that we found in this assessment was that, we didn't have the personnel to move that forward. And so that's what helped us. We didn't have the benchmarks, the efficiency benchmarks that go with that. We didn't have a validated tool. So these were some of the things that we knew that the assessment of the registry would tell us, but we knew things anecdotally. So we needed to have a process to move forward with that. And so that's one of the reasons why we went forward. Another part of that was we wanted to understand the return on investment. All these registries cost a lot of money, as everybody knows, but we wanted to understand, which of those registries were most valuable, and also how were they being used for performance improvement. And so the primary value of using the assessment was in knowledge for an informed strategy to move forward. Thanks.
Thanks, Claire. And speaking of bandwidth, which Claire just brought up, we previously mentioned how the healthcare labor shortage has had a really significant impact on hospitals. So Doug, what actionable solutions can an assessment reveal on this particular challenge?
Yeah, well, in healthcare, the labor shortage is something that we've been talking about for at least the past 2 decades. As the workforce, particularly the nursing workforce, has transitioned to alternative roles or retirement, it has meant that many frontline direct care roles have been short-staffed and relying on a much younger and largely less experienced workforce. And while the nursing profession has diversified and enabled a proliferation of alternative career paths to boost recruitment, this diversification really hasn't solved the basic frontline care needs many markets have been dealing with. The American Nurse Association estimates nursing to be the largest staffing group at almost 40% of hospitals' operating costs. And so when we think about the labor shortage in healthcare, we're usually focusing on nursing. And since supply is low and demand is high, ensuring that you're getting the highest value out of those nurses you have is critical. And what's interesting is this was true before the worldwide COVID-19 pandemic, and it's even more true now. As the World Economic outlook, looks to worsen and interest rates to curb inflation, healthcare systems are facing additional challenges to ensure safe staffing levels. And many health systems during the worst of the COVID-19 hospitalization waves saw their bottom lines wiped out by the loss of the more lucrative elective procedures that were being delayed due to the emergent population needs of the COVID-19 treatments. And so many now are faced with diminished bond ratings, higher interest rates, and a pretty significant burnout amongst those at the bedside. And as a result of all of these financial pressures, cost-cutting initiatives are paramount. And while the outlook, may seem bleak, there are several ways health systems can better manage their assets and investments. And that's really where the assessment comes in. The assessment is a tool by which we provide a focused analysis that highlights what the true costs are and how to better align operations to high value activities and reduce costs. With any investment, you want to keep a watchful eye on your returns and the market indexes or key performance indicators. And that's exactly what the assessment does for our health system's clinical quality data programs. It's a guide for smart investing and asset management. When 80% or more of the cost of clinical quality operations are tied up in staff or in people, it's critical that you have staff performing at the highest impact or value, especially when those staff are nurses. So we benchmark a health system's efficiencies against national data and outline opportunities for greater impact and utilization through realignment of top of license activities.
I appreciate that, Doug. And Ian, coming back to you now, reflecting on what Doug just shared, can you share your approach to optimizing your team while balancing these market conditions he just talked about?
Yeah, sure. My approach has always been to leverage the talents of each individual, and I try to match each person's strengths with a specific need so that I have more flexibility to move someone around by project or program. And I find that it leads to a stronger and more motivated team when they have some stake in the game. And having that flexible mindset also allowed us to have a workforce that had remote work options and flexible hours, which was to our advantage during these tumultuous times. And that being said, I think there were still some need to have better cross coverage and validation processes to ensure a sense of stability with our program. And so the partnership with Q-Centrix helped me fill those gaps.
All right, now bringing Daniela into the discussion here, Doug just touched on some of the measurements and benchmarks which go into the assessment. Can you elaborate on that and share in more detail exactly what are you assessing and what factors are measured? Who do you speak to? We're obviously hearing from a couple of those folks, but what stakeholders are involved as well?
Absolutely. So during an assessment, we're looking at the entire health system's clinical data registry participation, utilization, and efficiency. So this will include costs, excuse me, from staffing, participation, technology, and indirect sources. We'll compare your health system's efficiency to the Q-Centrix national benchmark data, like Doug had mentioned, while reviewing your utilization for quality and performance improvement processes. We'll take a look at how you're using the data for clinical research and even include select registries for clinical data validation and oncology platform analysis. Our collaboration is with various levels throughout the organization. So our executive stakeholders like Anne and Claire are typically system level quality leaders. They help us lay the groundwork for that data collection at every site. From there, we'll work with key service line leaders to identify points of contact that work directly on the registry or directly manage the people who do. These points of contact are our main sources of information during the survey collection process. And then we'll also interview physician champions that are identified for their participation and their perspective on things. Additionally, we'll contact your health systems finance and HR teams to help corroborate financial information we receive about different registries. Lastly, once the data is collected, analyzed, and pulled together, we work with our executive stakeholder to organize a meaningful conversation with the system C-suite executives. This conversation includes the data that we collected on participation, as well as a strategy component that our team will craft and individually tailor to your health system. This component focuses on the hard data, as well as the system perspectives gained through physician interviews and our weekly conversations with our executive stakeholders.
And Danielle, just one follow-up question to what you just shared. With all those items being included in the assessment, can you just tell us how long a typical assessment engagement takes?
Absolutely. So a typical assessment engagement varies on the system size. We typically try to complete an assessment around 16 weeks. That being said, it's heavily reliant on the support from the health system. The more support we have from the senior leadership, the more participation we tend to see from the individual health systems and physicians.
Great. All right, Claire, back to you now. And just by way of background for this question, at Q-Centrix, when looking at the hospital enterprise clinical data market, we're estimating the annual U.S. spend to be about $2 billion. So for as added context, for a health system with, let's say, 8 to 10 hospitals, that's looking like the annual spend is likely somewhere between 6 to 8.5 million. And given that those costs typically are not a straight line item in a hospital's budget, what we have seen is that the size of that clinical quality data spend is often quite surprising to a lot of health system leadership when this is revealed through the assessment. So Claire, reflecting on the assessment process and findings, what else was surprising to you?
You know, when we got the assessment back for all of us, one of the interesting things we saw was that the indirect costs were higher than we had anticipated. And that came from the survey telling us who was doing the abstraction, because some of them are high-level managers within a department who are also doing abstracting. So, of course, that's a very expensive labor pool. So that was interesting to see as it came back through the surveys. We also saw that there were some inefficiencies. So there's a high indirect cost, but then there's some inefficiencies of those who were doing that. And so, of course, that balance was not there. And then I think one of the last things that we learned from the data that was shared with us was because it is decentralized and it is run locally, is that sometimes there's not as robust transparency with the senior leadership on each one of their national registries and their metrics to benchmarks, and of course the cost of those registries. And so that was interesting facts that came forward in the survey that was, you know, part of cost analysis of how beneficial these registries are. And we also didn't see that they were using, you know, performance improvement based upon the registry utilization. So a lot of things that came back to make us, it brought anecdotal thoughts to actual fact from the survey. So it was very helpful to see that in order to strategize moving forward. Thank you.
Mm-hmm. And so far, we've heard a lot about different challenges related to efficient enterprise clinical data management. And I think it's important to also appreciate that there's many different milestones in this journey towards centralization too. And when discussing the value of centralized enterprise clinical data management, we often discuss this concept of moving away from just abstraction and moving towards analysis, then to integration of this data and ultimately impact with this data itself. So Anne, coming back to you, as I think about where you were at the start of the assessment, you had a large chunk of this centralization complete, and we're moving up this value chain of centralization. So even though you may have been further along than others in this centralization, could you elaborate on how the assessment helped you validate or maybe optimize your approach?
Sure, you're right. Several years ago, we moved our data abstraction from high-level staff or staff at the bedside to more a centralized model within the quality department. And we felt this would be more efficient and a better use of resources. We also made some difficult choices along the way to discontinue some registries that were either low yield or not required or mandated. We also changed vendors, you know, when the need arose. Those decisions were validated as part of the assessment, so it really helped us kind of make sure we were making the right decisions. And in terms of optimization, we still had opportunities, though, to improve our staffing model. And we had some staff still split between data collection and process improvement or project management. And the majority of their time was spent collecting data, leaving little time for improving care. So the assessment helped me quantify that opportunity cost and think through different staffing models, which we ultimately implemented. And, you know, I'm happy to say that that implementation was cost neutral.
Great. Thank you, Ann. So pulling the three of you in now here, Doug, Claire, and Ann, as former current leaders in healthcare systems, what would you each recommend for other leaders that may be somewhere in this journey that we're talking about to better understanding their enterprise clinical data management practices? And just to put some order to this, Doug, maybe let's start with you here.
All right, thanks, Eric. You know, I think everybody is somewhere on this journey, you know, with various regulatory reporting programs, you know, being mandated and registries as well. You know, trying to understand how your organization is utilizing its clinical quality data is really kind of a lifelong journey. And so, you know, where we all start and where we end, you know, is kind of unique to each health system. But what I would say is that in this work, you know, there are things that you can do to ensure that you have a seat at the table and that you are continuing to elevate this work and get value out of it. And it really goes back to making sure that you have a firm grasp on the ownership of the data. So, you know, understanding your legal contracting, understanding your security measures, and what data is actually leaving your organization and for what purposes. You know, and then you have the opportunity to look at how you're operationalizing that data. So I talk a lot about moving from nurse abstraction to analyst and the need to actually start getting good reporting. And then how does that empower quality improvement? How do you move the measure down the road? And throughout all of this, you know, one of the things that really underpins this work is just your governance strategy. So how have you brought physicians into the picture? How are you collaborating with them? How are you making sure that this information is transparent? It is being rolled up to the right levels within your organization. And so, you know, regardless of where you are, there's always work to be done to either maintain or continue to advance the work. And so, you know, I don't see this as a space that's going to go away. Quantifying quality is definitely here to stay. So it's just about understanding your current state and then where you want to go.
Claire, let's jump over to you next on this one.
Sure. I think some of the lessons learned that I would take away was that we did a lot of pre-discussions with clinical and quality, but we really didn't do a pre-discussion with our senior leadership because the assessment really can make some crucial operational changes for efficiency. And we would have gone back and showed them that it was going to be a 3-year journey after the assessment. So I think that's lessons learned. We've done that afterward, but we would have done that before. So that's lessons learned.
Mm-hmm. Ann, how about you?
Yeah, I mean, I agree with Claire that transparency and having those conversations up front are key. And I took a lot of time to have one-on-one conversations with key stakeholders to help them understand the need for the assessment, the specific ask, and then build a shared vision. And the other thing I think I would mention is to be open to redefining roles and responsibilities and be, you know, transparent with your team to help them prepare for those changes along the way and explain why it's needed and get their feedback. I think sometimes getting them on board is an important step. And like anything else, you know, this assessment, you're going to get out of it what you put into it. So that's my other, I guess, recommendation.
All right, Claire and Ann, you're not off the hot seat just yet. So one final question here. Now that you've completed an assessment or starting to implement some of these key next steps, where are you now? What's and what's next for you? And then maybe third part of that question is, what does success ultimately look like for OSU and CHRISTUS on this topic? So let's go Claire first on this one.
Sure. You know, based upon the assessment, we are embarking on a 3-year journey. The first part, of course, is the assessment. The phase 2 is looking at the strengths and the weaknesses of what the assessment pointed out to us. We're looking at centralizing contracts and also centralizing the registry management. And then phase 3 is going to be establishing the transparency, the dashboards, and of course, clinical governance. I mean, these are all recommendations of success that came through the assessment, but for us, we're a little bit earlier in the journey, is that, we're looking to how do we move those all forward. And so those are some of the things that would define success for us as we move forward. And we really want to see that the data that is being shared, abstracted and shared back with our clinical leadership, that we can move it into a performance improvement phases and move the clinical outlook for our patients better. So that's the signs of success for us. But we have really identified that it's going to be a 3-year phased journey to really incorporate all that we have learned from the assessment. Thanks.
Great. Anne?
Well, ours is similar, I think, to Claire's journey. My main goal right now is to minimize the silos and create a more formalized governance structure so that we can evaluate the value of participating in new registries consistently. I think everybody's kind of going after a new shiny object every day, and having that centralized governance structure would help deal with some of the contracting issues and data security risks. And there are obviously some other larger business decisions that frequently come up, and having that kind of a governance structure would give us, a sounding board for those things. We're also in the process of developing a report to analyze the data across multiple registries to help us prioritize our efforts. Having all that data at your fingertips is wonderful, but unless you prioritize it, I think you end up maybe spending time on lower priority projects. So we're adapting an outcome summary that Q-Centrix compiled as part of the assessment to give us a better line of sight to those key performance indicators that have opportunities for improvement, try to discover common themes across registries, and then not only track initiatives underway, but really, show an impact based on that data.
Great. Great ending to this discussion. And with that, I want to send a big thank you to Claire and Anne for sharing your insights on the assessment experience and the journey that you're on right now. I did see a few questions, and we have about 10 minutes here or so for audience Q&A. And again, I did see a few questions come in. And just as a reminder, if you have something on your mind and you'd like to ask today's panelists, please go ahead and send that question into the Q&A button located on your participant control. Let me open that up and let's go through a couple of these here. Doug, maybe starting with you, and then Claire and Anne, if you have some feedback on this one, by all means, jump in as well. And the question is, how do you define ROI, or return on investment, for clinical quality data? And can you give an example of this?
Sure. So, when we talk about your investment in the space, it's all of the costs that go into producing this data and hitting the submit button, hopefully. And when we think about what the returns are in this space, there's a number of different ways that we can look at that. I think one that we all want to see is, now what do we do with that data? So one of the returns on investment is, how are you utilizing it? Are you incorporating it into your management meetings? Are you using it as a tool for quality improvement? Are you utilizing the data that's being collected? These are really rich data assets. And so one of the things that we're looking at are performance improvement, quality improvement, but also, are you using it for research or any real world data initiatives? And so, once data is structured, it has a immense power. And so that's one of the areas that we look as a return on investment. And then, we're looking at the opportunity cost also associated. So, are you utilizing your staff to the best of their capabilities at that top of license? And so you can, actually reduce your costs in many instances by, better management, of these teams, or through other partnerships, for external services. So there's a lot of ways that you can look at it, both from the overall kind of intangible impacts for an organization, but also the financials.
Anne or Claire, anything you'd add to that?
I guess the other thing, there are definitely fixed costs for each program or registry that you participate in. And so those are things you can't change. The things you can change are kind of the inputs, which are the staff or the way that you collect the data. And I think trying to automate as much as you can is something that we're looking at in terms of reducing our costs that we can. And then, when I think about some of the other opportunity costs with these registries, I think about, the reimbursement implications for participation, kind of how you can use the data with managed care companies in terms of contracting and either pay for performance or, other incentive programs. And also reputationally, having that data to share with consumers and the public about performance, I think is another maybe intangible opportunity cost.
And also, and thank you. This is a great question. Return on investment. I agree with what Ann and Doug have talked about. Is that quality management and registries go hand in hand. And so, we pay a lot for the data to show where we stand against the benchmarks nationally. And so there should be crucial conversations happening back inside each hospital to say, where do we stand? Because if you can achieve benchmarks and get into high percentile rankings of those professional registries, you're going to see lowered length of stay, lowered mortality rates, greater patient outcomes, greater satisfaction. And so it's a great way for that particular clinical specialty to look back upon themselves and determine, where do they stand? Is there an opportunity for improvement? And so I think, return on investment to make sure that the abstraction is done efficiently and effectively, but also to get back in front of those clinical leaders to see whether or not they do have any opportunities for improvement. And so when we did the assessment, we were looking for, there's all this data out there, everybody's getting the reports. What are you doing with it? Where are you tangibly coming back to improve bedside care? And so that's what we kind of defined as ROI. I mean, we don't, no one really minds. Well, we do. The minds the expense of a registry. However, if you're going to spend that much to know what your benchmarks are against your own professional organization, you should bring it back in-house and see how you can get even better. So thanks.
All right, let's go to another question here. And there's a number of open questions. We probably won't be able to get to all of them, but another one that Claire, I think you touched on this a little bit in some of your comments, but I'll open up to the whole group here. Is there a certain level of executive engagement necessary for this to be successful? And Claire, I think this was part of your observations on the process. So maybe we start with you and then ask Ann and Doug to jump in on this one as well.
Sure. When you're dealing with abstraction or registries, it's data. Excuse me. And so, you're talking to all your clinical executive leaders to make sure that this quality management process is going to be assessed and looked at and potentially changed. But as I said in my prior comments, is that, in involving as many executive leaders as you possibly can, because part of the assessment indicated that we had inefficiencies in abstraction. And so when you look at that data and you figure out, well, how can it be done more efficiently and effectively, it could potentially affect people who are currently in those roles. And so that's something that, the senior operational leaders need to understand, that this assessment could bring forward that information. And the other part is knowing that the assessment can also indicate whether or not, we have appropriate systems to reflect back on ourselves. And so the more people that you can get executives on board as you move into the assessment, I believe the better.
Ann or Doug, anything you would add on that?
Yeah.
Doug,
all
go
right,
ahead.
I came off mute first, I guess. Healthcare to me is a team sport. And when we look at this work, we see that it takes a team to accomplish it. And there's not one person in an organization who fully owns all clinical quality data management. It's everybody's responsibility. And so, when you look at who should be included, oftentimes you want to see those service line leaders at the table. You want to see your C-suite at the table. You want to see HR and finance. It takes a team approach to do this work well. And, the more that you're getting those inputs, from those leaders, the more you're going to be able to be change ready and manage change well within your organization.
I was just going to add a specific example, I guess, in terms of, let's say, the STS registry. You know, I made sure we talked with our physician champion, the medical director for the heart hospital, the lead for perfusion services, the administrator for the heart hospital who paid, you know, the registry fees, you know, our chief quality officer, you know. So I think just as an example of the level of people, you know, it's sometimes the people kind of operationally or clinically in a position that have some ownership of the data, and then also the C-suite people. But it's really important to get some of those frontline folks involved as well.
All right, one last question here to bring us home for the time we have allotted, and this question is: do you have any tips for changing to an enterprise governance structure? Maybe Doug, if you can take it first, and then we'll look at how much time we have left after that.
Yeah, I think, you know, first you have to have a shared vision for centralization, and you know, generally that's going to take a lot of relationship building across the organization, and it really is centered around trust in my mind. And so one of the things that's really important as you embark on that journey is just making sure that there's transparency, there's agreements for how data will and will not be used, how it will and will not be shared. You know, we don't ever want to weaponize data in clinical quality. And so oftentimes once you have talked through the processes and protocols that you're establishing, you know, you're building trust with those individuals. And then it's follow through. It's making sure that, you know, you continue to keep those lines of communication open and engagement. You know, one of the ways that oftentimes you can get started in this space I mentioned earlier is just having good governance processes just around the basics, around contract management, around platform access, and just ensuring that there are standards and controls there. And usually from there, you're building trust and then can start getting into what's the data actually saying, what's the data fidelity, what are the improvements.
Ann and Claire, I saw some head nods. So with the minute or two we have left here, Ann, starting with you, any additional comments that you'd make on that?
You know, if I had an answer to this one, I think that would make my life easier. But the thing I'm trying to do is not duplicate effort either. You know, we have a HIPAA steering committee and a data security committee and, you know, strategic planning folks. So I'm trying to, you know, pull it together without duplicating effort, you know, to make that governance structure work.
Claire, any last thoughts?
No, I totally agree with what Ann and Doug have shared. No additional comments. Thanks.
All right, perfect. Well, all right, well, that concludes our webinar on Q-Centrix assessments, the blueprint to unlocking value in enterprise clinical data strategy. And again, thank you, Claire and Ann, so much for joining us today, being transparent about the journey you were on and sharing your insights on the assessment experience that you had. Also, thanks to the Q-Centrix experts, Doug and Daniela, for joining us. If you have any more questions, I know there's a couple that we didn't get to, feel free to send them in to qc_events@q-centrix.com, and we'll be sure to respond to those. We'll circulate amongst this group and get you some answers. As I mentioned before, recording of this webinar is going to be sent to everybody along with a copy of our recently released case study around assessing your clinical quality data investment to all the registrants within the next week. And finally, as you exit the webinar, you should see a link to a survey pop up in your browser, or you can just click on the link that is now available in the chat. Either way, absolutely works, but we encourage you to complete this and let us know if you found this discussion of value. And with that, thanks again so much for everybody that participated as well as that joined us here today. Have a great rest of your Wednesday.